Now, this session is about the future of practice-based research, and I would like to start by introducing Drs. James Harrison and Nynikka Palmer, who are co-principal investigators of the Here with Community project funded by the Patient-Centered Outcomes Research Institute. Dr. Harrison is a researcher and implementation scientist who partners with patients, families, and community members to develop and evaluate solutions to improve the hospital care transitions of older adults. His vision is to transform health systems so that older adults are at the center of innovative discovery. Dr. Harrison is also the research director of the UCSF Health's Age-Friendly Health System, and in this role he seeks to build capacity and research infrastructure to support research that improves the engagement, outcomes, experiences, and dignity of older adults within the health system. Dr. Palmer co-leads the Prostate Cancer Task Force of the San Francisco Cancer Initiative and is the director of research education component of the Center for Aging in Diverse Communities. Dr. Palmer has a long history of commitment to health equity research. Much of her research focuses on developing actionable solutions with cultural influences to enhance delivery of high-quality prostate cancer care for African American men. Community engagement is the foundation of her work, and she believes the community's voice and involvement are essential to advance research and optimize healthcare. And so I'm going to turn the mic over to them, and they're going to lead us through a really, I think, very exciting and wonderful workshop where we hope to hear what you think. Thank you.
Thanks, Mike. And thank you, everyone, for coming back after lunch. And I know there's another breakout session. You've chosen the best one, so really appreciate you being here.
Well, look, I guess our evaluations will tell us so, right?
Yes.
So welcome, everyone, to our practice-based research opportunities for the SFBayCRN. Specifically, we are talking about the project that James and I have been leading here with Community. And first, see if I can get this to work. Oh, thank you, Mike. First, I want to do some acknowledgements. Our study team includes Dr. Mike Potter, Saji, our staff member who's been helping out. Also want to acknowledge all of our study site collaborators, including Benioff Children's Hospital, Oakland, with Gina Lewis, who I hope is in the audience. Yay! How you doing? The Family Healthcare Network with Carlos, Dr. Carlos Sanchez. Maybe, no? And the UCSF Fresno Stuti, Dr. Stuti, she is unable to join us today. And then the San Francisco Community Clinic Consortium with Dr. David Offman. And then the UCSF CTSI, the Clinical and Translational Science Institute, including Dr. Tung Nguyen and Paula Fleischer. Also must acknowledge the people who gave us money to do this, the Patient-Centered Outcomes Research Institute.
And also just our advisory board. There's a table of them over there. They're going to be, we're going to give them a shout out later.
We're going to get to them, yeah. So our advisory board members, raise your hand. Yeah! We couldn't do any of this work without them.
Especially, some of them came from the Central Valley and left at 3 this morning to be here.
So they deserve an extra round of applause for that.
Okay, so the roadmap to our presentation today, we're going to go over the objectives of the Here with Community project. We'll go through our methods, and then the main part is us just presenting to us the recommendations from this study. And then what's going to happen then is Mike Potter's going to come back, and we're going to have a discussion with all of you about the recommendations that we've presented, and you're going to tell us what's important and what should we prioritize moving forward. Then we're going to have a break, and then we're going to come back and do another interactive kind of breakout session, and we're going to prioritize some COVID-19 research topics. So we've got lots going on this afternoon, and really appreciate you being here.
So just keep in mind that this session is a little bit different than what you heard in the morning. There's going to be some things that could be very repetitive, but essentially what we're focusing on today is one, we want to hear from you, so not just presenting all this information to you, but we want to hear from you, which is why we have all this interaction occurring throughout this 2-hour time period. So our 2 objectives that we're focused on for this project is to identify, thank you, James. Identify recommendations to facilitate and support health equity for COVID-19 research between academic and community health centers. So we're not speaking of the community in general, but specifically with regards to our relationships with community health centers. We also are working to create infrastructure and processes and a foundation to support stakeholder engagement that accelerates health equity research on COVID-19 in community health centers. So if you see the acronym CHCs, that's what we're referring to, but I'm also going to try really hard not to use a lot of acronyms today.
So the methods to our study, the first part was really creating and then maintaining a stakeholder and community advisory board. And this board advised us throughout the whole project. It met every 2 months. It's provided input as we've developed the study, as we've implemented it, and interpreting our study findings as well. We have 11 members representing the organisations that you can see on the screen now. And really, everyone brought a unique perspective, and we're so thankful that they came and spent their time with us and gave us their expertise. We provided compensation for our advisors and also for the community health centres in Fresno, in San Francisco, and Benioff Children's Hospital, Oakland. We gave money to, provided money to the community health centre as well.
So specifically with regards to our methods, we conducted various focus groups, some of which turned into interviews because you can imagine how hard scheduling can be with folks. And so some of them were one-on-one interviews, others were focus groups, and we ended up having 25 participants, which consisted of or represented 13 clinic staff and leaders, 11 academic researchers, and 1 patient and community member. So you can see here the distribution of 4 participants from Benioff Children's Hospital, 7 from the Family Healthcare Network in Fresno, UCSF Fresno, and the San Francisco Clinic Consortium, Community Clinics Consortium, and then the UCSF CTSI. So just as a note, what you might notice is that we only had the 1 patient community members. Don't worry, we have a few more coming up where we're meeting with patient and community groups in the Fresno and Central Valley area next month.
So now moving quickly to our results, just some kind of overall big picture results that we found, that it's really challenging to do research in community health centres. They have been structured and they're set up to provide clinical care, not to engage in research. And what we found is that even though most community health centres have community advisory boards, talking to community members and clinic staff, patients and community members on those advisory boards aren't engaged in research. And when we did speak to them, we were told that they can't really talk to us about research because they've not been exposed to it. We found out that academia, not surprisingly, and community health centres are really siloed. And I would add to that silo, there is definitely one thing we found, the silo between San Francisco Bay Area and Fresno, and then even thinking about the other areas in the Central Valley, Tulare County and Kings County, another silo compared to the academic kind of operations of UCSF. We did, though, in our conversations with participants, we did get numerous examples of individual projects and research projects that had been successful partnerships between a researcher and a community health centre. But the thing was that there was no real systematic engagement or infrastructure to support partnered research long term. And you'll see over the next few slides the recommendations from our focus groups and interviews and advisory board. Some are very broad about building a foundation to community engaged research, and then others are very, very specific. And Nynikka is going to start to go through these with you now.
So there was a lot that was presented to us throughout all of these focus groups. So we thought about this from a multi-level perspective. And so what we're going to present to you are the recommendations based off of categories. So if we're thinking about this from a multi-level perspective, we're going to give you the high-level policy recommendations that were suggested, community health center and academic partnerships. So what happens between the community health centers and the academy or academic institutions like UCSF? What could we be thinking about at the individual organization? So whether you're thinking about UCSF specifically or whether you're thinking about a community health center. And then what happens between the interpersonal interactions between researchers and community health centers. So, and then the final level being education. So thinking about that like in the interpersonal, like what's happening, or intrapersonal, what can we do as individuals in moving these recommendations forward?
We're going to go through these different categories. You've also got a handout that summarizes them as well. So firstly, from a policy perspective, we heard loud and clear that academic medical centers should invest in clinical partnerships with community health centers. One idea that I think was given from Stanford had done with some community health centers of the academic medical center partially supporting some staffing time of clinic staff, maybe whether that be 20% of their salaries from the academic medical center and then the rest of their time is in clinic. We had suggestions about academic medical centers and community health centers working together to create equity-focused research agendas and strategic plans. We're also told that with organizations such as Benioff Children's Hospital, the Family Healthcare Network in Fresno, that really there needs to be ongoing systematic engagement between senior leadership and UCSF and community health centers to kind of talk about research. Often research agreements and processes had not really been thought out or discussed when mergers or clinical partnerships were happening. Then there's examples given about building infrastructure such as the data registry, having staff within community health centers that can really catalyze and facilitate research.
So between the community health centers and the academic institution partnerships, some of the biggest things that came up was to raise bidirectional awareness of academic institutional programs and resources with community health centers. So we all have all these assets that we bring to the table, and we should have bidirectional understanding and awareness of what each person or each entity brings forth. So for example, how UCSF has the CTSI, and the reason why we're here today, the SFBayCRN, and other resources that might be available to community health centers as well. Also the need to provide up-to-date information on clinical needs and partners, like who the partners are and personnel. Maybe there's personnel needs. So the example at the policy level was about perhaps doing a joint partnership with hiring people that could be a part of research that maybe the academic institution covers along with the community health center. The other thing is providing resources around IRBs, memorandums of understanding, and also electronic data sharing. This is a couple of challenges that have come up. There was also suggestions around a centralized resource or point person, perhaps a custodian of information at both academic health centers and the community health centers. They also brought up focus on activities that build relationships to cultivate a sense of community and partnerships. So for example, that might mean that UCSF might bring brown bag lunches or for CME presentations to talks or continuing medical education presentations to the community health centers, and perhaps town halls to actually share topics of issues that are coming up within either from the patients, from the community, so that these topics are being shared across the board. Two other final recommendations that came up was to build a system-wide relational, not transactional, so that's come up a couple times this morning. Partnerships between the community health centers and UCSF. And then finally, academic researchers should have a physical presence within the community health centers, and that was another thing that you might have heard earlier this morning, is to actually show up, be present. We don't know, the community doesn't know us, so we should actually be there for the community.
And so now moving to the things that individual organizations can do, and this could be UCSF, it could be one of the care delivery systems that we interacted with, or community health centers. one of the things that we heard was about creating guidelines for engagement for researchers. This was kind of, researchers said to us, we struggle doing this. We struggle working in community health centres to do research. And then community health centres also told us it can be a nightmare working with researchers because they have no idea of our context and kind of how care's delivered, and then you're asking us to do more stuff. So we kind of, this idea of guidelines, creating guidelines for kind of engagement with community health centres has came up a lot. We also had requests from community health centres to kind of leverage the academic centre's infrastructure and resources. Is there an opportunity for assistance with real-time to accessing, processing and displaying real-time data, data at the clinic level? Is there an opportunity for UCSF or academic centres to provide their expertise to conduct program evaluation? And another thing across all organisations, we heard from our participants, we really need to value and prioritise community-orientated research to really kind of foster the interest and then kind of engagement in this work. Researchers who were trying to work in this space spoke about a need for infrastructure that supports their research agenda. So having dedicated space, having protected time, having staff or having some startup funds to do research would be really helpful for researchers wanting to, actually trying to or doing research in this space.
It's you.
That was me again.
More of the individual level.
So we're back to more individual stuff. Researchers commented about the need for affordable and accessible translation services. Obviously, a lot of patients going to community health centres, English isn't their first language, so research was like, how do we include them in our research? There was certainly a lack of awareness of UCSF there was a lack of awareness of UCSF researchers about resources that are becoming available through the CTSI. Community health centres suggested, maybe having a formal review process for fielding research ideas prior to grants being submitted. The last thing they want to do is hear from people once the grant had been submitted. They wanted to be involved in grant development and project development so they can kind of partner with researchers to talk about resources, space, personnel, community engagement activities and so on. And then the final suggestion in this category was about creating a matching system or repository of information where community requests could come in to connect researchers and community health centres.
So moving to the interpersonal level, so what's happening with academic researchers and community health centers, there's a little bit fewer than what we just presented, but I think this is the point about that there's a lot of things happen. There are some projects, research that's happening between academic researchers and community health centers, but there's a lot more barriers or issues that are happening at the higher level, which is why more of our recommendations illustrate that. So at the interpersonal level between academic researchers and community health centers, there was this recommendation to invite the community to show you your blind spots. Find your own blind spots, but engage people as partners who come from those lived experiences that you do not already know about or have experience with. So, we see this a lot, and I think this came up a lot in some of the earlier presentations, but if you don't have representation within your team, there could be a problem with that. It's probably not going to be well received. Other piece that came out was to create research projects that actually align with the needs of the community health center.
And then the final category related to education and training. We definitely heard from community health center leadership that, what's the value proposition? What's the value to them of doing research? There were questions they had about, why they should be doing research in their settings. I think that academia and UCSF could do a much better job of kind of working with community health center leadership to kind of walk through that process and why it could be a valuable endeavour for partnership. And then for those researchers working in community health centres, they know, and particularly those out in the Central Valley, we did hear that they would like more access to research education and support locally rather than having to access services at the main campus.
So just to give you a brief summary, and we did want to make sure you have a physical printout of all of these recommendations because we're now moving to the point where we want to have an open discussion with you all. Again, I just want to acknowledge the fact that we did have a limitation in that our focus groups were really focused on the 4 partners that we mentioned. And so I just want to make sure that it's an understanding that this doesn't necessarily represent all community health centers or relationships with academic institutions. So this is a snapshot of that given the partners that we have at the table. The other thing is that I mentioned earlier is that we're currently missing more of the community and patient voices, but that is to come in the next month. We have a few more focus groups that we'll be doing with community groups and organizations in the Central Valley area. Finally, again, just want to summarize this multi-level perspective of the recommendations that we were really trying to hit at what should be happening at higher levels that I must admit is above my pay grade, but wanted to at least provide suggestions on policy level issues that could be addressed. Also, reminding everyone that we talked about the partnership between academic institutions and community health centers, and then what each individual could be doing, individual organization could be doing at their level. How do we interact as individuals with our community health centers, and then what could be happening internally with our education and training process to help move things forward.
And we are going to ask Dr. Potter to come back to lead this discussion.
So this is a more facilitated discussion. Dr. Potter is going to help us with this, and we will chime in as needed.
Okay, and we're going to be asking people in the audience to respond. Are there microphones to go around for people to respond?
We can run around.
I think a lot of recommendations, right? A lot of suggestions that came out of these interviews, and I want to thank James and Nynikka for taking the leadership to really help us with this work to do a better job of partnering with community health centers. And I think not all of you work in community health centers, in fact, probably most of you don't, but I think that this is relevant to other health systems as well, this type of work. So I think just to start, is just ask you for any reflections you have on the list of things that came out, and maybe let us know what you think should be emphasized or is missing from the list of things that you saw from your experience. Would anyone like to start? Or maybe some of the folks from the Community Advisory Board have some opinions that they would like to share or add. There we go. Can you introduce yourself?
Hi. I don't mind getting the ball rolling as you all are thinking about what to say. I'm Anjana Sharma. I'm at the Department of Family and Community Medicine. I'm an assistant professor there, and I do research on patient and community engagement. I think the main takeaway is that the best principles of community engagement, when we talk about community, community health centers as stakeholders in primary care are also a community. And so just the core messages of stakeholder engagement, I think, are there and really resonate loudly. I think just the other piece, I feel like the elephant in the room is the funders. And it's, what proportion of funding genuinely prioritizes primary care. And so that's going to slant any researcher who's then filtering through to try to engage with community health centers. And so that's my soapbox on that piece. But so I don't know if that could maybe be a policy recommendation as well.
Thank you. I think that's a really good point, Anjana, about often when we think about community engagement, we think of different groups, and health systems are not often considered as being part of the community. They're considered part of the power structure or whatever it is. But actually, clinicians are a community unto themselves, and the health systems they work in are part of the community. And there's often perhaps not that much engagement between the health systems and the other folks in the community. And I think that's one of the things that we would want to prioritize, is not to have these, you don't just need bi-directional relationships. You need multi-directional relationships where the community is interacting with the health center, is interacting with the academic center, and the academic centers back to the patients and so forth, so that we all have connections with each other, and that really facilitates quite a bit. And I think that's one of the reasons why we have this meeting today. Sharing with Impact is trying to break down the silos between community and clinical healthcare settings. So any other comments about the list of things? Yes, you have over here. If you have a microphone, right here. Oh. It'd be great. I think people could hear you better with a microphone. We have time. Can you just introduce yourself?
My name's Eileen Oba, and I'm a community person. So I might have missed it in your presentation, but I thought I didn't hear what is the benefit for the participants. How are they going to benefit from this? You guys are going to benefit tremendously, but how are they, each individual, going to benefit? And when the results come out and the studies come out, how are they going to know about it, and how are they going to benefit from that?
Agree. I think that's part of I'd say that came through with the discussion around what is the value proposition. Health leaders were saying, well, how does research going to be of value to us as an organization, but also what value is it and impact does it have for patients coming to our clinics? And I think there needs to be a much better job of articulating that to patients and community members.
I'll just add that I think the other piece of that is, this is why one of the recommendations was to have community-oriented research or initiated research. So while I'm a researcher at UCSF doing lots of different things, I want to have my ear to the ground or with my patients or my community members to actually see what are the problems that they're experiencing that we can collaborate on. And I think that's one of the things that's been missing, is having the research question, if you will, start in the community first. Before as researchers we go to you all, we need to be coming to us. And in a way that I mean, like, I should be coming to you asking, what is it that you want? What is it that you need? Because we want to benefit the patients, the community members from start.
Sorry, one more thing. Just what we heard loud and clear was that many community health centres have advisory boards, community advisory boards, where up to 50% are patients or community members. But talking to clinic staff and some of the few community advisors that were on those boards, they told us, we haven't really heard about research. We're not interacting with research. So again, I think there's another opportunity for us to do kind of better outreach and maybe for engagement and reaching out and engagement about research.
Yeah, I would, there's more questions. I just want to add, I think a lot of times when there are research partnerships, the results are shared with the research collaborators, the people in the clinics who are partners. But I think that was an outstanding question, because I think that sometimes there might be an innovation that happens in the clinic and the patients don't even realize that it had anything to do with a research partnership. And so I think we need to do a better job of not just telling the people who we think are our co-investigators in the community about our results, but to make sure those results actually get to the people that they're serving. Rana, you were pointing to...
Hi, my name is Lucinda Bazil, and I actually work for a federally qualified health center. So I'm really excited to see the beginnings of something that could be really great. But I want to just piggyback on the fact of what the young lady just said. The population that we deal with, of course, is untrusting of research. So we have to do a better job of educating not only our staff, but also our communities about the importance of it. And we've been doing that with the All-In project. And when researchers come to the health center, they come when they need a letter of support or a letter of interest. And so even if it's at that level, it needs to be an engaged conversation to get to the level of what will we get out of it, how will it benefit our patients, And what do we need to do to be involved? So I think there's a lot of education that needs to be done with researchers, like you said, to understand who we are and who we serve, and how overworked and underpaid we are, so that people do not want to just say, oh yes, I'm interested in doing it, even though they're passionate about wanting to do it. So there has to be an avenue to have that happen. And there needs to be a cheat sheet, and I'm sure there is already, that explains to the health center, this is how you get involved, and this is the steps that you need to take to understand what an IRB is and what your role is. Because we don't have time, but we want to do it. So in order to do that, there has to be some engagement to make the process smoother and easier. So I have a lot to say, but that's
Can you share with us which community health center you work with? I didn't catch
Lifelong Medical Care in Berkeley.
Okay, shout out to Lifelong, and we'll be in touch, right? Other comments? I see some more hands.
I think there was one over here. Oh, there we go. And then, yeah, go ahead. Go ahead.
Great. Okay. Yes, good afternoon. I'm Lena El-Saraf. I work at a community health clinic actually based in Los Angeles. Thank you for this. It's very enlightening. I just want to share, I would love to see research done on the challenges of being a provider at a community health clinic. I mean, I had to attend the CUGH conference, and I was sitting in learning about global health when it dawned on me that some of these struggles that they're having are struggles we're facing here, whether it's health literacy, not only dealing with the medical aspect, but it's dealing with, immigration, it's dealing with poverty. I mean, there's so many issues down the line that, we're trying to manage. And so it would be great to have that research so we can figure out how to effectively work with the patients and really educate them and also, have better outcomes.
Any reflections or? No? Thank you. Can you say which, you came all the way from Los Angeles? I think you must be the farthest coming person to come to this meeting, so thank you for coming.
I work with Asian Pacific Healthcare Venture.
Wow. Well,
Thank you.
Thank you. Other reflections or thoughts? You can move on to some other questions.
Okay.
I think we also would like to know what SFBayCRN, CTSI, and UCSF can do to help support these changes. Yes.
Yeah. Okay. My name's Lali Moeno, and I'm from Tulare County. That's in Visalia, on the way to Sequoia National Park. That's the only way people know where it is. That's where we're from. And we're the ones who got up at 2:30 in the morning. 2 people. Okay. We're glad we're here, by the way. Mine's mostly a comment, but I also want to hear them talk about what I'm going to say. We're in Tulare County, where a lot of these discussions that we saw this morning, which were excellent discussions, excellent work that's being done in San Francisco, we do not have those services in Tulare County or in King County. That's Hanford. Okay, so according to one of the doctors I talked to a while ago of the Fresno presentation, they only get to Fresno. And they're trying, because I asked him, how come we're left out? We're still at 50% or less of vaccination. We are the county that we cannot go to a meeting to ask for the schools to have policies or to have the children vaccinated. Every time we go, we have to confront the Republican Federation or the GOPs in our meeting. We get harassed at school board meetings. So our schools have not been able to do any policies in vaccinations. They just leave it up to the people, whatever they want to do. They're catering to the political parties. So, we're looking at this, and I asked Dr. Harrison, this is so nice. It's like a dream come true if we could have that being done. As long as the Central Valley, San Joaquin Valley, which is further down, Tulare and Kings, as long as we have the issues we do, We're never going to finish with COVID. We have a lot of COVID in the rural community, and they're still dying today. Tulare County has one of the high death rates, if you look at the news. They're still dying right now in our area. The children are still very sick, and it's going to be like that. So whatever, Fresno is doing an excellent job with the two doctors that were up there. I thought it was wonderful. And I wish that they would somehow go down, but I am so glad that finally Dr. Harrison and Dr. Palmer will be going down. And we have volunteered to help, and we volunteered to be on their advisory board. But I wanted you all to hear, that's why I wanted to comment, that this is not happening in our area, okay? And I want you to help the university. Maybe you want to go intern over there. Help us, okay? And it's bad, guys. I don't know about Kern, which is Bakersfield. I'm pretty sure it's just as bad. It's Stanislaus, Madera, Fresno, Kings, Kern.
Right, so what I'm hearing is thank you so much. Thank you for being part of the board and for all these months, and also just for coming all the way up. I think that really speaks to the need for us to not just focus on the usual local places when we're thinking about forming partnerships and doing research. We need to expand to the areas of real need, and in the Bay Area we often forget about our rural communities. I think that's really what that's about, and how we connect with those clinics in those settings to partner is not easy, and hopefully you can all help us. Did you want to reflect on that?
Lali, you and I have had many discussions about this, and yeah, you've highlighted what we've heard over and over again is how people feel siloed and isolated from all this great work that's happening. And, even talking to, UCSF Fresno colleagues who are part of UCSF feeling that too, as researchers, as clinicians, and as community members. So, I think this project has certainly highlighted even more so that we need to think about our catchment area and engaging much more broadly.
Some more questions or comments?
I have a quick comment.
Your name, please?
Maria Carvajal, part of the board.
Can you remind us from which organization? Yeah.
The research. I'm a volunteer promotora with Family Healthcare Network.
Thank you.
And I think that kind of answers the question that our friend asked over there. That's what the community gets in response, to be heard. To be heard of our disparities that we have in our communities, the loopholes, the problems. And if it's been working up over here in the San Francisco Bay Area, then probably it could work down there. What's working here? Can we take it over there? What other communities can we expand to improve these services and these communication? Because that's what I think we're lacking, communication within the leaders, the health centers, and also us delivering it to the underserved communities.
I think one of the things that it's coming to my thought is that one of the suggestions that could be up there that's specific to the Fresno area is that CTSI really could facilitate some conversations between the healthcare providers and the community in that setting to try to see what we can do to build some new partnerships. That's my thought.
Maria Echeveste. I wear a number of hats, so Benioff Children's Hospital board member, but also on this advisory committee. I wanted to say that what Lali said is an example of what could be a research question on polarization, community engagement. I guarantee you political scientists are looking at polarization. But what if you partnered in a multidisciplinary way to understand the health implications of, say, a Tulare County versus Marin County, which could, more data, more evidence to let science guide our policy. And this is a benefit of hearing from community.
Yes, thank you. Any other hands up? There we are in the back. your name?
Hi, I'm Jennifer Lavin. I'm a research lab manager at the San Francisco VA Medical Center with investigators that are also UCSF affiliated. So we keep talking about scientists being in silos. I think a big part of the reason that scientists are siloed is because our funding is siloed. So I'm just wondering, is anybody talking to NIH about the time and money it will take to do, to connect with community organizations? It's just not something that's ever in our budget. There doesn't seem to be any support for it. So, even though at the VA we do have access to some UCSF resources, and we're also lucky that we're a healthcare system that's nationwide, so we have our nationwide network of veterans and doctors. It would be really interesting to hear about how this kind of effort gets funded.
I'm wondering if, did you want to say something, Nynikka? Because
I can.
I was going to suggest that, and not to put anyone on the spot, but if any of our CTSI leaders want to be put on the spot, and maybe Sharon, you have some thoughts about that, because we're going to be thinking about, in the next year or two, we're going to be starting to think about the next CTSI grant. And we're going to be making proposals about what UCSF does to try to be more community engaged. So I don't know if you have some thoughts about that yet, or maybe it's premature, or Nynikka, if you had some thoughts.
Or if the CTSI wants to marinate on that, or any representatives from the CTSI want to marinate on that.
We're so glad you're here.
While I at least say, I definitely appreciate that comment, and that's one of the reasons why we wanted to present in this forum, because what's discussed here, what we have found thus far, is being taken back to PCORI. So PCORI funded us. So this is the Patient-Centered Outcomes Research Institute. They care about these questions and recognize the fact of how much time it takes. And so we're trying to gather all this to take it back to them, because they're basically then going to start proposing program announcements to start applying for funding that can actually support these kind of questions and this kind of work moving forward. I haven't been engaged with NIH around this conversation, but that's certainly something we should be talking about too.
And just to add that PCORI, we meet with our project officer regularly, and she has said to us, this is one of the first projects that have looked at engagement with community health centres and federally qualified health centres related to research that they've funded. So, and they've said that this is a priority for them, and hopefully just the beginning.
Yeah. Tung.
And then
we have about 2 or 3 minutes, and then we're going to break into our groups. So just someone else first? I didn't see. Yes, thank you.
I just have a quick comment.
And your name?
Gina Lewis.
Oh, Gina.
Hi, pediatrician at Benioff Children's Hospital, Oakland, FQHC. Really happy to be here with all of you. So just like money is an issue, time is an issue, and I think about how much clinical research we've done at our FQHC and how great that is to participate in. And I think about the impact it has on our patients and our providers and our whole clinic. There's a lot of pressure to see patients quickly. And it's the part about medicine that I hate the most. There is no way I will ever see a patient in 15 minutes ever, or 10 minutes. It just doesn't happen. So then throw research on top of all of the pressures to see a patient in a holistic, caring way. And it's very difficult, as I'm sure we've all been talking about all day and we'll continue to talk about. So, but I also am thinking about it from the patient's perspective, echoing what was first said about the experience. What does the patient get in the moment? They're coming in for their appointment. They're asked to participate in research. It prolongs the visit. It means more, coming back for more. And what do they get in that moment? And do they leave feeling like they received something valuable that day from their participation? And yes, they're going to, hopefully hear about what comes of the research, and they're going to contribute to hopefully valuable information. But what do they get in that moment?
Thank you. Was Paula or Tung? I don't know. You each had your.
And then Tung.
Go ahead. All right. Those will be the last two.
Hi, my name is Karen Gersten-Rothenberg. I'm a family nurse practitioner at La Nynikka. And I just wanted to make a comment and ask if you would consider doing more of this. So our best experience with research has been when the researcher also does some clinical time with us. So particularly some of the people from the School of Nursing who are working with us maybe even just a day or two a week and then doing research have really been able to straddle both organizations. They understand the needs of our patients. They understand our time constraints. They understand the university. They've been able to just do a lot of that legwork that otherwise would fall on me or someone else. And their approach has been like very patient sensitive, very staff sensitive. So I just feel like those projects have been kind of the best of both worlds and get around a lot of the issues that have been brought up here today. And I know that those people also have huge loads, right? They're teaching, researching, practicing. And so I'm just wondering if you've thought about that and about ways for the research with community health centers to look a little bit more like that model.
Yeah, I think that's something we always try to encourage people when they ask us for a consultation. I think that's a really great point.
It was also an explicit suggestion that was made. So we kind of hinted at it earlier on in our talk, but having basically a researcher who's also a clinician share time between the academic and the clinical institution where, for example, UCSF covers perhaps 20% of their effort, the clinic covers the 80%, and that person is the one doing the research collaboration with the clinics. So that's something that has come up. It's something that I think more places could be talking about.
Hi, Teng Nguyen, and I'm now wearing the hat of the Associate Vice Chancellor of Research, Inclusion, Diversity, Equity, and Anti-Racism, and also as a multiple PI for CTSI. So, and Hao had to run off. He's one of the other multiple PI for CTSI, and he told me I can speak for him. So I do want to respond to a couple of things. So the first issue around what we're going to do at UCSF, I have to say this whole issue of community engagement is actually one of 4 pillars of our Task Force on Equity and Anti-Racism in Research report. So investing in community engagement broadly speaking, and that includes community health centers and how that involves in the research environment is really important for us. So nothing specific right this minute, but it's definitely a high priority area for us. And it also goes beyond the CTSI. CTSI is only part of the overall UCSF research enterprise. And with Hao and me and Sharon and other people, our goal is to really push this institution to be much, much better than we have been. So that's the first sort of general response. The second one is in terms of what the community gets out of this. And I totally agree that we can't just expect to take things from the community and not bring back enough resources for the work. But I have to say that research goes on whether or not your community members and your patients are involved or not. And it generates data that leads to policy and practices that affect your patients. So the reason why we think it's so important beyond just working with community members and patients is it really does affect them eventually, one way or the other. And so we want to make sure, I run the diverse participant research core at UCSF. The reason isn't to just make science better for scientists, it's really to make it better for patients. And the lack of participation, and it's not on them, it's on us, really affect that. And so the kind of things that we come up with from an evidence-based perspective is inferior because we don't involve your patients.
Thanks. Good. Thank you so much.
So now we're on to the end is nearly in sight, and we really appreciate you being here. We're now going to work on the next part of this breakout, which is around prioritizing COVID-19 research topics in general and research topics. As we mentioned in our previous session, PCORI, the Patient-Centered Outcomes Research Institute, is really interested in finding out, well, what is important to community members, what is important to stakeholders in this arena that they can kind of hopefully fund research in the future. So as part of the focus groups and interviews and with our advisory board, we asked that question, what is important for your community? We were overwhelmed with the number of kind of questions and topics that came up, and there's just a summary on screen now that you can see, ranging from topics related to vaccines, long COVID, healthcare and health outcomes and disparities research, trust in healthcare around addressing misinformation, and anti-racism, just to name a few. And so this afternoon, we're going to have a session with all of you where we're going to try and take these and other questions and try and find out what you think are most important topics to move forward. We will be giving everyone's suggestions, and everything that we have received from our focus groups and from today will be sent to PCORI, the funder. But the purpose of this afternoon is to kind of work in small groups, and we'll talk about what that will involve soon, to kind of come up with a prioritised list of COVID-19 topics that really focus on health equity.
All right, so we do group process?
So we're going to get everyone into smaller groups now, and then you're going to meet your facilitator for your small group and a note taker who will then talk you through the rest of your time with us today. And then Nynikka and I will be running around the room helping you all.
So we'll move around, but the biggest thing I want to acknowledge is, number one, we have multiple facilitators and note takers. If you could just raise your hand, I just want to appreciate you for joining us today to help us do these small groups. And keep in mind that if you raised your hand, you don't need to count off, but we want everyone to count off. And we're counting off to 7 or 6.
6.
Okay. Okay, so if we could start over here perhaps. So as long as you are not a facilitator or a note taker, please count 1 to 6, and when you get to 6, the next person next to you is going to start back to 1.
And remember your number.
And yes, please remember your number. We're going to have all the tables up here be 1 through 6 or something like that.
1, 2, 3, 4.
Over here? To the left? Uh-huh. 3?
3.
Okay.
Our board members. 1, Maria C.
No.
Oh, no.
No, she's not. She's not. No, Maria C is not facilitating, so you're 1. Lolly, 2. Carrington, 3. Did I do this group? 4. Uh-huh. All the way in the back? No, 2. Okay. Back here? Uh-huh. Okay, I can't see. Okay, 5. Good thing I don't have to hear this. 2, 3, 4, 5, 6. Yes. Okay. So while folks are counting off still, my facilitators and note takers. 1, 2, 3, 4, 5, 6.
2.
So group 1, table 1. Group 2, table 2 right here. Group 3, table 3. Group 4, table 4 right here. Group 5, table 5. Group 6, table 6. You all might have to move, is that okay? Or switch tables.
No.
Okay, that's a great point, Maria. Thank you.
So.
What? No,
Okay, so so my brilliant community advisor mentioned to me that maybe the table shouldn't be assigned so closely, so I'm going to take heed and listen. So table 1, table 2 all the way in the back. Table 3 is still table 3. Table 4 all the way in the back right there where the ladies are still sitting there. Table 5, still 5. Table 6, all the way in the back corner. Maria, does that do it, Maria? All right.
I feel like we should. And you get one.
And you get a car. And you get a car.
So,
all right.
So has
hopefully
everyone found their
everyone
group?
has found their tables. 1, 2, 3, 4, 5, 6. All right. All right. Now, if everyone is just about situated, we're going to give you some instructions, and your lovely facilitator, please raise your hand for the facilitator at each table. Raise your hand if you're facilitating. Wonderful. Your lovely facilitators are going to take charge and give you instruction, but I'm going to give a quick instruction right now.
Go ahead.
All right. So in your small group. Okay, can I get everyone's attention because we're coming back as a larger group? Thank you all for putting in the hard work to identify the key COVID priorities. I want to explain just briefly what's about to happen. So as we call on each group, you're going to have your note taker. I'm just going to assign the note taker or facilitator can share what the top priorities that your group identified. And we're going to live type it up on the screen so everybody can see what's happening. Because once we have them all up there, hopefully all on one sheet, even if it's small text, we're then going to decide, can we identify amongst all of us as a group what we think the top 3 to 5 must be. Okay.
And just,
so
and just so you know that even though you're telling us your top 3 to 5, we're recording everything you've told us. We're capturing all of the questions. Nothing will be lost.
Right. So do not despair. If your comment, your suggestion doesn't make it to the top, it's still on our list and PCORI will still see it. All right, group 1.
Group 1.
So the issues that we talked about, the number 1 was trust. Okay, got it. Trust, mental health. We also talked about anti-racism being really important, and then healthcare delivery. And we also talked about misinformation in there, and that can either be a separate one or combined with trust.
Thank you, group 1.
All right, group 6.
All right, our number 1 was mental health. 2 was institutionalizing lessons learned to be ready for the next crisis. 3 was vaccine hesitancy or skepticism, and 4 was long COVID.
We're going to let our
Cecilia
note
is in the
taker-
back typing this up. Cecilia, do we need to repeat?
The last one, please.
Okay.
Vaccine hesitancy or skepticism was our last. Yep, you got it.
All right.
Okay. This group? Thank you. What group number? 1, 2, 3. Group 3.
Okay, well, y'all correct me if I get something wrong. Mental health definitely rose to the top as a huge priority. We have, 10 or 12 bullets under mental health. So plus to mental health. Telehealth, access questions. Telehealth as a means of reducing access, expanding access. The telehealth as a potential solution to mental health challenges and disparities, and then also addressing access to technology and use of technology. So a bunch of questions around telehealth and technology. And then another one that rose to the top, I think, was the effects of the continuation or discontinuation of COVID-related policies, like expansion of Medicare, Medicaid. So a whole bunch of questions around policy, the effects of policies.
You're not going through the full list.
No, I'm not.
Thank you, group 3.
All right, we're going to come back here to group 4.
Hi, everybody. We're going to add to this list yet another plus for mental health. And then This is long, but I think boils down to something that's already up there. Healthcare delivery models, studying those with the aim of increasing access to care for underrepresented communities in the context of existing inequities and disparities. So a broader frame to study healthcare models to increase access to care. And we also have misinformation, especially with an important note for immigrant populations. Information transparency and trust is connected to that. Did I forget something, Maria?
The only one I would add that kind of relates would be ethically engaging underrepresented communities.
Ethically engaging underrepresented communities. Hopefully you got that, Cecilia. All right. We're now going to... We finally done voting. Oh.
Okay, we'll do group 5.
They needed the extra time, so we're going to go to group 6.
5.
Oh, you are done? No, it's okay. Yeah.
So group 5, we had trust in healthcare and science, particularly how the impact that will have on future health issues. Number 2 was mental and behavioral health, with a special attention to children, but not neglecting people of all ages. Also understanding that there were both positive and negative impacts, and perhaps studying those people who demonstrated resiliency and learning from those folks. And lastly was healthcare delivery, the backlog, but also the therapeutic alliance moving forward and the ability to build trust between patients and doctors and how medicine is practiced, and also the burden of providing mental health care that falls on the primary care physician or the family physician. And then all 3 of those kind of seen through the lens of health disparity and anti-racism, since that permeates everything as was demonstrated in COVID.
Thank you, group 5.
Group 2 represent. So we had 5 that rose to the top and a really, really rich discussion. Our highest was outcomes and disparities related to COVID. And then that was closely followed by seeking innovative and sustainable models that leverage technology. Then was healthcare workforce support and sustainability, and access to services, specifically for prioritizing populations such as limited English proficiency populations, and anti-racism. And I think that's it. That's 5. We got it. We did it, everyone.
Give yourselves a hand.
Yeah, well done, everyone.
Now we get to look at this full list together. Yes, Carrington?
We've got... one question. Hold on, Nynikka. I've got one.
I just wanted to make a slight edit to our list where it says healthcare disparities, anti-racism. We really want to put that under healthcare delivery and building a new healthcare delivery system that is equitable and anti-racist, addressing mental health with a lens towards equity and racism. I just want to ensure that you understand we feel it goes with everything because it's such a big deal.
Thank you for that. We also have a clarifying point for the mental health.
And that was the mental health as it relates to seniors, especially around isolation and loss.
Seniors, isolation, and loss. I can't see, so I'm walking closer. Therapeutic alliance was omitted. Is that what you're saying? Okay, so therapeutic alliance needs to be added back. Under healthcare delivery, perhaps? Okay.
And we will have all your notes from your note taker as well. So we will be capturing everything. Nothing will be lost.
So I'm seeing, yet again, a very big list. I'm seeing trust, Mental health was mentioned numerous times. Anti-racism, healthcare delivery and all of the complicated things within that. Misinformation, access to technology, health disparities, anti-racism, which is actually kind of a duplication. So I'm seeing those coming to the top, the ones that I mentioned. Can we agree that that might be our top 5 as a larger group? So Cecilia, can we put them in bold or red? So trust, mental health, anti-racism, healthcare delivery, misinformation. Those are our top 5. Yes? Okay, and just keep in mind, we are still keeping all of this and reporting all of this as a full list to PCORI, and of course, when we produce results. We have 5 minutes to spare. Actually, maybe not, because we have other people walking into the room. But comments, questions, and actually, before I do that, can we all please give a round of applause to our note takers and our facilitators for your small group? And let's not forget the on the live typing Cecilia back here, our medical student helping us.
Live TV.
Other comments, questions before we wrap?
Oh,
Paula?
Definitely.
Yes,
Definitely.
we are figuring out plans to disseminate this, not just in a publication, not just to PCORI, but to you all as well, to the SFBayCRN network. So if you've attended, we want to make sure this gets back to you as well.
Yes. And then one last task for this session. We're going to hand you out an evaluation for this, just for this session, this breakout, and you let us know how this went for you. So
this is a very important part. Can you please complete this one-page evaluation that really only has 5 important questions? And if you fill it out real quick, leave it at your tables or give it to James or I. We can hold on to it. Thank you so much.
Thank you, everyone. Appreciate it.
Thanks.